Well, thank you very much, Jan. Really, very kind comments, modest comments, because I think that both you and David have been absolutely fundamental to put that together. I have to give credit to David Birne for the birth of these rare cardiac centers, and of course to your great leadership, Jan. I'm very excited. This is the second webinar, 50% increase. This is amazing. And I cannot think about a better topic of rare cardiac conditions to put ahead this concept of heart teams and how we can address as a team of experts, not only locally, but nationally, internationally, very difficult problems. The team is basically, by definition, the sum of different skills. And so in these rare cardiac conditions, there is no more place to put an addition of different skills than this particular theme of rare cardiac conditions. I think it's going to be good for patients, for their families, and to have this in Canada. And I think really this is a brilliant initiative, and I'm very proud of this achievement for the Heart Institute. As you said, I am stepping down at the end of next month, but as probably most people know, the Heart Institute will be in very good hands with Dr. Rob Billens. He's a terrific leader as well, a great cardiologist, world-renowned. He has the Heart Institute in his heart, and he will continue to the role of important role of the institute in the nation. I just want to first of all to say thanks to all of you attending this meeting. And I've seen the program is very exciting. This is really well construed, very well done, and I'm sure everybody's going to be happy. I want to take the opportunity, though, before I hand you, Mike, back to you, Jan. The Canadian Cardiovascular Society last October, has launched a new initiative, which is called the Canadian Canadian Alliance for Canadian Cardiac Center. The Canadian Alliance for Canadian Cardiac Center. This is a great initiative. We have many cardiac centers in Canada, but they need to talk more to each other, to share in new initiatives, to share how they can improve and harmonize the care of cardiac patients across the nation. It's a great initiative for lobbying, advocating for our patients, and they asked me to kind of chair this alliance and help have a strategic plan for this alliance for next year. Next CCS meeting will be, I think, in Vancouver, and there are already a great excitement around these centers. What I'd like to do today is for everyone who is on the call outside Ottawa, make sure that your leadership in your center is part of this Canadian Alliance, because I'm going to put rare cardiac conditions as one of the topics that could be evaluated and studied through the Alliance to help anyone to get engaged in this initiative. So basically, this is, again, a great initiative, and we need to have everybody on board. We have a lot of people already from basically each provinces. I think we have people from BC, we have Saskatchewan, Manitoba, Alberta, we have one center at least. So this is a great initiative. We have even from Quebec and Newfoundland and of course Ontario. And I cannot think of a better other platform for you guys who are in rare cardiac conditions business to really advocate and go see your leadership and say, please join the Alliance so we can really benefit from all the things that are done around the country. I'll stop there. I wish you a great day, guys. Thank you for joining. This is a great initiative, and I'm very proud of the work that has been done by Jan, who is, as you know, the director of the Ottawa Center for Rare Cardiac Conditions. Thank you again.
Thank you, Dr. Mesana. Those are great words, a great call to action. So yeah, we call on all of you to approach your leadership locally to inquire about what initiatives can be done for rare cardiac conditions. So I have no disclosures. Now, some of you might be asking why we're holding the meeting on today's date. Last year, we held our meeting on February 24th. And when we were planning for this year's meeting, Dr. Andrew Crean, who is one of the original founders of the Canadian Centre for Rare Cardiac Conditions, pointed out to us that actually Rare Disease Day is celebrated on the last day of February. And lo and behold, this year is a leap year day. So it absolutely made sense to hold today's event today. And in fact, there are many other events around the world that have been organized to mark this occasion. And in fact, the Canadian Organization for Rare Disorders is holding a 2-day event right now, just down the street from us in downtown Ottawa. So just to set the table for the rest of today, what is a rare disease? Well, approximately 7,000 diseases have been classified as rare, and 80% have a genetic basis. And given the large number of diseases that we have, it's been estimated that 1 in 12 people has a rare disease. Importantly, 95% of diseases have no approved treatments, and many of the drugs that have been approved are unfortunately not easily accessible. However, governments are starting to take note, and in fact, in March of last year, the Canadian government announced the first ever National Strategy for Drugs for Rare Disease, which is a $1.5 billion initiative over 3 years. This will include funding to support a clinical trials network and improve data collection for evidence-based decision-making. The Canadian Centre for Rare Cardiac Conditions is a virtual hub that was forged at the Ottawa Heart Institute and was recently launched last month. This center promotes excellence in the care of patients with rare cardiac disorders, enables innovation and discovery research, and educates patients and healthcare providers. We already have excellent existing programs within the center, and this year we're pleased to announce the launch of 3 new programs. This summer, we'll also be welcoming our first fellow in Rare Cardiac Conditions Fellowship Program. And I invite you all to go to our website for more information on these initiatives. With this in mind, we've planned an exciting conference for everyone today. This morning, we're going to hear from national and international leaders in the field of rare cardiac conditions. And you'll see that this year's conference themes revolve around discovery science, precision medicine, and advocacy. This morning's plenary is divided into 2 sessions. And there'll be a short break between the two sessions. And this afternoon, many of you will be joining 2 subspecialty sessions, each 90 minutes. And we'll give you more information about how to join those sessions later this morning after the plenary sessions are done. A few housekeeping items. I'm pleased to report that we again have been approved for 6.5 hours of Group 1 credits from the Royal College. And we'll be sending you your attendance certificate by email after the conference. Most of the sessions today will be recorded and will be available for viewing afterwards. Each morning plenary session will be followed by a Q&A session where we'll invite you all to provide questions in the chat. You'll all be muted. And then if we have time at the end of the session, we'll also have a discussion panel where you can ask questions. On behalf of the organizing committee, I'd like to thank our sponsors for today's event. They've each provided unrestricted funding to support the logistics around hosting a virtual event of this size. So thank you very much. And with that, it gives me great pleasure to introduce my co-chair, Dr. David Birne, who will be moderating our first plenary session. David?
Yes. Thank you, Ian. I don't know if I'm spotlighted yet or whether you can hear me or not. I just see Ian. Here I am. Good morning, everybody. Ian, I don't know whether we should wait right till 8:30 just in case some folks are going to join at the 8:30 mark, or do you want me to filibuster and tell some jokes?
Let's see, what time are we?
Yeah.
Okay, sure, we can, it's as you wish.
Yeah, I'll maybe just add a comment to what.
Yeah, why don't you add a comment yourself?
To what Thierry said, and thanks, Thierry, for introducing us. You know, it's wonderful to see this this conference start to grow in this session, and this concept starting to grow. And the idea really is to share all of this knowledge across Canada for benefits of patients across Canada. And you know, my idea behind this came from my own experience with cardiac sarcoidosis, and Plenary and I set up Canada's first cardiac sarcoidosis clinic in 2008. And, you know, we started to get referrals from across Canada, and it was very clear that, you know, a lot of physicians felt uncomfortable looking after these rare cardiac diseases. And a lot of patients felt uncomfortable about being looked after by physicians who are uncomfortable. So the thing then grew, and we could see, you know, Pablo and I could see how much we were learning from having a large number of patients with rare cardiac diseases, and then it seems that, you know, a lot of that was translatable to other diseases. The other thing I just wanted to add is just to highlight the fellowship program. This is an initiative of Ian's. It's brand new. It's accredited by the university. And, you know, and we see it, you know, open to national Canadian fellows. We see it open to international fellows. We have some in-house funding, so the fellow doesn't even need to bring his own funding or his or her own funding. We also see the fellowship program as being quite flexible. You know, fellows can come and have a small component of clinical work and a large component of research, or vice versa, or 50-50. They can also choose to major in one disease and minor in 6 diseases, or major in 2 diseases and minor in 1, or you know, so very, very flexible programming. So, you know, hoping that you will spread that fellowship program amongst your own institutions. So I filibustered for 2 minutes, Ian, and we're still got 2 minutes left.
No, you've done a wonderful job. Yeah, we'll be also highlighting the fellowship program later today as well. But yeah, it would be great to see. As far as we know, we're the only center for rare cardiac disorders in the world. You know, we've talked to Dr. Crean about starting one in the UK. He has goals set to start one there. But it would be great to see similar initiatives across Canada, across North America, across Europe, really around the world. It would be nice, you know, really to become an international organization, much like rare diseases has become. Yeah.
The rare, you know, from your understanding of the rare diseases organizations, Ian, there's very little focus on cardiac rare diseases. It's mostly on, you know, childhood cancer and
genetic, yeah, mostly childhood genetic disorders. So that's right. Very, very little focus on cardiac. Although, you know, this being said, there are some therapies now for cardiac disorders, rare cardiac disorders, which we didn't have 5-10 years ago. So it's an exciting time to be working in rare cardiac diseases, actually.
Okay, we've filled the time. So
yeah, there we go.
let me get on and introduce our first speaker in our first session of precision medicine. So really pleased to have to introduce Dr. Marianna Fontana, director of the UCL CMR unit at the Royal Free Hospital in London in the UK, professor of cardiology and honorary consultant cardiologist at the National Amyloidosis Centre at UCL in London, a deputy head of the centre and deputy clinical lead. She's obtained her medical degree from the University of Pisa, and then was appointed director of the CMR unit at the Royal Free in 2015. She was awarded with an intermediate fellowship from the British Heart Foundation in 2018, recipient of many awards, really a rising star in the UK and in international cardiology, including the Michael Davis Early Career Award in 2021 and the BHF Fellow of the Year Award in 2022. Her major clinical and research interests are in the delivery of efficient and effective care for patients with amyloidosis, with a particular focus on new technologies. imaging and drugs, and an excellent person to open our conference. Marianna, take it away.
Thank you very much for the very kind introduction. It's really a pleasure for me to be here today. And as mentioned, it's a great day to have this conference because it's the Rare Disease Day, to raise really awareness of these diseases. So my talk is really about imaging of early detection and disease surveillance. And I have taken the case of cardiac amyloidosis as an example of what really imaging can do and how imaging can completely transform the pathways, diagnostic and treatment pathways in rare diseases. So when we think about imaging in general in cardiology, I would like to start from what is wrong with what we have. So first of all, our imaging is extremely imprecise. So this one is a short axis slice seen from a cardiac MRI. So very high quality. There's nothing really that I could say in terms of quality on this image. And what we did, we asked 10 international imaging experts, and I'm talking here about head of departments or people who write the guidelines on imaging. We asked them to measure the maximal wall thickness on this exact picture. And this is what we got. As you can see, there is a lot of scatter, even amongst international experts, up to 1 centimeter in some of the cases. So we use every day in clinical practice wall thickness to define disease, but yet is a test which is probably not really fit for clinical use. The second problem is that when we try to classify cardiac pathology, we did so based on alteration in structure and function. So, for example, we define hypertrophic cardiomyopathy as an increase in LV mass, LV wall thickness in the absence of loading condition able to explain it. The problem is that by doing so, we're extremely far from the underlying pathophysiological mechanism which is responsible of the disease, of the patient's phenotype and the disease progression. The third problem when we think about imaging in cardiology is that our link to therapy is extremely poor. Very different is in other branches of medicine. If you think, for example, about oncology, we have some beautiful examples of drugs with specific pathways, and then a nuclear medicine tracer that can image that specific pathway. In cardiology, in terms of link between imaging and treatment, we couldn't be more far. If you think about ejection fraction, we all use very precise cutoff in clinical practice to take decisions which are important to patients and to society, like SCD implantation, for example. And yet, we are all happy to live with the fact that if you measure ejection fraction with echo and MR, you're going to get 2 different numbers. If you measure with echo, 2 different operators will get different numbers. So again, we need to get a better link between imaging and therapy. So in the next kind of 25 minutes, I will be talking about these 3 problems, and I will show where we are in relation to these 3 problems in cardiac amyloidosis, taken as an example of rare disease, of how the imaging has really advanced the management of our patients. So echocardiography is really the first imaging modality we all do in any patient that presents with heart failure. And what we commonly see in patients with amyloidosis is concentric hypertrophy, very commonly asymmetric, atrial dilatation. In the past, we used to describe the specular appearance of the myocardium, although now we know it's really a non-specific finding. We used to describe this population as heart failure with preserved ejection fraction, but we know that ejection fraction is really not a good way to describe systolic function in these patients' populations, because typically the longitudinal function is severely impaired. In terms of diastole, usually there is severe diastolic dysfunction, and also pleural and pericardial effusion are very common. If we want to add some specificity to the echocardiographic examination, we've been told to do strain. With strain, what we do is we assess the extent and timing of myocardial deformation during systole. And what typically happens in patients with cardiac amyloidosis is that there is significant reduction in the contraction, longitudinal contraction of the basal segment. and there is preservation of the longitudinal contraction on the apical segments. And this gives a very typical bullseye appearance when we display these values segment by segment in the polar plot map as shown here. So fundamentally what we do, and we can do that by just thinking in our head and pulling all the measurements together, or actually by using formal scores like the one you see here on the right. What we do is that when we see a patient with an hypertrophic phenotype is that we take a lot of different measures, a lot of different parameters, and then we can try to work out the probability of one disease compared to another. And this, in this case, for example, of cardiac amyloidosis. So we try to stratify the probability of cardiac amyloidosis in this case. But what's absolutely impossible is like to have, I don't know, 10 patients and to be able just on echo to say, oh, this patient out of the 10, I'm certain is the one with amyloid. Because really structure and function is not enough. And what we've been taught in medical school is actually to get a diagnosis of cardiac amyloidosis, you need a cardiac biopsy. So cardiac biopsy, the problem is that it's rarely performed early on, it's only really performed in end stage, not in many patients. In the UK, it's really not very common to do a cardiac biopsy. Then, so we could do, okay, let's do a screening biopsy, like a rectal biopsy, abdominal fat biopsy. But if you look here on the right, the diagnostic performance, for example, fat biopsy as a screening biopsy is extremely poor, especially in ATTR amyloidosis, where can be as low as 15% in patients with wild-type ATTR amyloidosis. So it's a very ineffective screening tool. But then let's say we want to go for a cardiac biopsy. So I've got patients where I suspect amyloidosis, I skip everything else from echo, I just go for a cardiac biopsy. So we did an audit across the UK where we provided cardiac biopsy, perfectly beautifully stained to pathologists, and we said, can you just score presence or absence of amyloid? And the results were very surprising. In 1 of 4 cases, we got a false positive results, and in 1 in 10 cases, a false negative results. And as you can see, there was no trend whatsoever of improvement over the years. And why was that? So we learned that congregate staining goes off, so it needs to be refreshed. If there are pathology department where that is not used very much, is a problem. Then we learned, to our surprise, that 20% of the UK pathology department don't have polarizing microscopes. But still, also we learned that the expertise is extremely important, because even if you give the perfect staining slide, 13% of assessor will fail to demonstrate amyloid, where amyloid is there, and this is just down to really the expertise in reading the congregate. But then the challenge is not stop here from an histology point of view, because once you have proven the presence of amyloid, then you need to type it, and typing is extremely complex. So the most widely used is histology immunohistochemistry with a wide range of antibodies. But really the gold standard is becoming mass spectrometry, which is available in very, very few centers. For example, in the UK, we are the only centers performing mass spectrometry as a clinical test. And what really completely transformed the diagnostic pathways is not really like histology or get access more to histology, do more histology, but has been imaging. And the 2 imaging techniques which did that were cardiac MRI and bone scintigraphy. So with cardiac MRI, what we do, and this was established more than 25 years ago, is that we give contrast, and by the distribution of contrast within the myocardium, then we can assign a specific phenotype, a specific diagnosis in a process known as phenotyping. And so what we learned is that in cardiac amyloidosis, the appearance on legal enhancement can be extremely pathognomonic. On the left, you got normal subject, the blood is gray, and the myocardium is black. And on the right is a patient's with cardiac amyloid. The blood is black, and you see this line, which is called subendocardial legal enhancement, which is throughout the subendocardium. And so this like great utility of CMR in the diagnostic pathway has been incorporated in the guidelines. And these one are the European guidelines, and characteristic CMR findings have been described as diffuse subendocardial or transmural legal enhancement. So transmural is when the whole myocardium is white, as you see on the right, coupled with what we call abnormal gradient kinetics. So the blood becomes black very early on. And then you will see that also a measurement which is called extracellular volume is extremely useful in these patients. The second imaging modality that has really made a step change in the diagnostic algorithm was bone scintigraphy. So with bone scintigraphy, what we do is very simple. We use a bone tracer to look for any evidence of cardiac uptake. And the way we grade it, again, is very simple. Grade 0, no cardiac uptake on planar and SPECT images. Grade 1, 2, and 3, there is an increase in the cardiac uptake and decrease in the bone uptake. And this was probably the most important paper diagnostically that was published over the last 25 years. And this paper established that if we suspect cardiac amyloidosis, then cardiac ATTR amyloidosis, when we should do a bone scintigraphy. And if we find a bone scintigraphy of grade 2 and 3 in the absence of a plasma cell dyscrasia, then we can confirm a diagnosis of cardiac ATTR amyloidosis without the need of any biopsy. And this was really the extremely informative step. And the only extra thing that we need to do is TTR genotyping to see if the patient has got wild type or variant TTR gene. But it's absolutely essential to confirm normal serum immunofixation, urine immunofixation, and normal free light chain. So all these three tests needs to be negative to say the patient doesn't have a plasma cell dyscrasia. So you have seen the role of echo, the role of CMR, and the role of bone scintigraphy. So how do we integrate these three modalities in the clinical practice? When we think about clinical practice as cardiologists, we've got two scenarios when we think about amyloid. One is more rare, patients with known systemic amyloidosis, and then we want to know if it's cardiac involvement. And one is patient with systemic with an hypertrophic phenotype, and we want to know if it's amyloid or something else. In the first case, where a patient has known systemic amyloidosis, we've got two possibilities. One is known systemic TTR, like, for example, a patient with neuropathy. And then in that occasion, you can really proceed straight away with bone scintigraphy. Bone scintigraphy is extremely sensitive and specific. However, we need to keep in mind that some of the mutations bone scintigraphy can be negative. Instead, in patients with systemic AL amyloidosis, it's absolutely key to do a cardiac MRI because bone scintigraphy is positive only in 40% of the patients with cardiac AL. But then what about the role of advanced imaging modality in the hypertrophic phenotype? So in the hypertrophic phenotype, so when I see a patient with myocardial hypertrophy, CMR definitely has got a much more important role because it will give an answer on yes, is amyloid, not is not amyloid, but also we answer on a wide range of existing differentials. And I'll give you now a few very quick examples of how the integration of these three imaging modalities works in clinical practice. This one is a 70-year-old gentleman with shortness of breath. Echo showed a symmetric increase in LV mass, and this patient didn't have a plasma cell dyscrasia. So what we did was a Perugini, DPD scan, which was grade 2. And so you can follow the right side of the algorithm that we discussed, and DPD grade 2 with no plasma cell dyscrasia, you already know this is ATTR amyloid. And the only extra step you need to do is TTR genotyping. This one is a different case. This is a patient that, again, shortness of breath, increase in LV mass, but this time the patient had MGUS, so a plasma cell dyscrasia. The patient was referred with a suspicion of TTR because the local physician did TTR genotyping and found V122I genotype. So we repeated the CMR entirely characteristics, but actually on the CMR, we also saw that there was liver and spleen involvement, which shouldn't be the case in TTR. And on the bone scintigraphy, there was no evidence of cardiac uptake. And indeed, the patient falls in this side of the algorithm, grade 0, with yes, plasma cell dyscrasia, review the CMR, because if the CMR is positive, then the most likely thing is actually the patient has got cardiac AL amyloidosis. But what about this third case? A 60-year-old lady with shortness of breath, echo showed increase in LV mass, and there is again no plasma cell dyscrasia. The bone scan, there's no cardiac uptake. The CMR has got mid-wall layout, which is extensive, but completely different from the amyloid distribution. This one, we are on this side of the algorithm, grade 0, with no plasma cell dyscrasia, then the probability of cardiac AL or ATTR is extremely low. And what the algorithm says, review the CMR. In this case, the CMR was actually in keeping with hypertrophic cardiomyopathy. So you've seen how really the combination of use of echo, bone scintigraphy, and CMR has completely transformed the diagnostic pathway in patients with cardiac amyloidosis. And especially cardiac MRI and DPT have been shown to be extremely useful even in confirming the diagnosis of amyloid. So they've got a very high accuracy because they are able to answer the question on, you see a patient for the first time, you want to know if, in this case, the patient has amyloid or not. So these techniques are very accurate. However, when we see a patient for the second and third time, the type of question we want an answer to is completely different. Is a precision question. And one of the errors that we do as cardiologists very often, do it all the time, is to take a technique which is very accurate and trying to use that technique to answer a precision question. And I will give you an example here. This one is a patient with ATTR amyloidosis associated with the mutation V122I, so it should be a quite aggressive form of amyloid. These images have been taken at 3 years interval change. And what I hope we can all agree on is that definitely this patient has got cardiac amyloid. However, I'm pretty certain that everybody, just based on this image, cannot say if the patient is better or worse. The wall thickness is the same. I can tell you systolic function is the same. And the laggard is just everywhere. So, because the problem with laggard is that it's a non-quantitative technique. So whilst it's very accurate, it's not very useful to actually track changes over time. And what we need to do, if we want to track changes over time, is image biology and measure specific pathways. And we can do that in amyloid, we use T1 mapping. With T1 mapping, what we do is that with one breath hold, 8 seconds, we get one of these pictures, which is a non-contrast T1 map. So pixel by pixel quantification of T1, which is one of the myocardial properties. Then we give contrast, which just goes into an extracellular space. And by repeating the same image 15 minutes after the contrast, then we get one of these one, which is a pixel by pixel quantification of the extracellular volume. And why is the extracellular volume important in amyloid? Because the amyloid sits in the space between the cells. So any increase in the amyloid will increase the extracellular volume. So the extracellular volume is really a surrogate marker of amyloid infiltration. And this one is why extracellular volume is relevant in clinical practice. These are 2 patients with ATTR amyloid, same degree of increase in wall thickness, same degree of systolic and diastolic failure. But actually, if you look at the extracellular volume map, the difference in infiltration is striking. The patient at the top, 39% extracellular volume. Patient at the bottom, more than 60% extracellular volume. So patient at the top is only mild to moderate infiltration. The hypertrophic phenotype is predominantly intramyocyte hypertrophy, whilst the patient at the bottom, the hypertrophic phenotype is driven just by severe amyloid infiltration. And if I go back to the example from before, and I show you now the extracellular volume map, straight away, you can tell that the patient has massively progressed over 3 years. The myocardium has gone from green to red. The extracellular volume went from 45 to 67%. And because the extracellular volume in both types of amyloid is a measure of the amyloid burden, it doesn't surprise that it does correlate with prognosis. The higher the ECV, the worse is the prognosis of the patients. So I'm a cardiologist, so I've been doing this for years. And then if you give me any picture, the first thing I do is just zoom into the heart. And Professor Hawkins, the founder of the center, has always told me, Marianna, there are other organs that exist outside and you actually image them when you do your cardiac MRI. It took me many years, but when I decided to look outside, I noticed that in 95% of the cases, when we were doing cardiac MR, we were actually imaging the liver and the spleen. And why is important? Because in systemic AL amyloidosis, spleen and liver infiltration can be extremely severe. It's very common, and it really drives disease progression and prognosis. And on the left, you see a patient with completely normal ECV on the spleen and the liver. And on the right, a patient where there is no cardiac involvement, but large amyloid load in the spleen and the liver. So in one single picture, you can get information about the 3 different organs. This was validated against 550 SAP scintigraphy, which is the gold standard to measure extracardiac amyloid. And now we just use it in clinical practice. It's the only thing that we need to do. And cardiologists like me shouldn't be scared of doing it. I've been scared of doing it for many years. They just throw a simple region of interest in the liver and the spleen. And because if you do that, the diagnostic accuracy is actually very high. With the ECV has got with a cutoff of 40%, has got a area under the curve of more than 0.9 to identify moderate to large amyloid load. And this is just a representation of how you can really kind of image the complexity of the patients in one single picture. Because in one single picture, on picture A, you see there is cardiac, liver, and spleen involvement. In picture B, just spleen infiltration. In picture C, there's actually no infiltration at all. The heart, liver, and spleen are clean. And picture D, you've got just hepatic infiltration. But then, can we go on to the next problem? So the last problem, can we link our imaging to treatment? So first, this is a paper that was kind of published a couple of years ago. Strain assessment in cardiac AL amyloidosis can be useful in assessing treatment response. So what we do in these patients, to switch off amyloid production, we give chemotherapy. And so measuring the change in the longitudinal strain actually adds prognostic information on top of the traditional way that we use to assess treatment response, which is basically cardiac biomarkers. But what about cardiac MRI? Because one of the problems is that strain is great and biomarkers are great, but really not imaging specific pathways. So can we just follow the amyloid load over time? This was a study done in 180 patients almost, published in 2022. And what was done is that patients were imaged at baseline 6, 12, and 24 months with cardiac MRI multiparametric mapping, whilst the patients were having chemotherapy. And what we found is that amyloid regression, it takes time. So at 6 months, almost no patients had regression. But actually, there was progression in quite a good proportion of patients, even in the patients where the degree of hematological response was very, very good. And we learned that it wasn't just a problem of reaching a good response, but the time to response was incredibly important. Because if you take too long, the patients will accumulate more amyloid. And this is just an example of a patient with progression. You can see that the ECV goes nicely up. But at 1 year, what we realized, to our surprise, is that amyloid regression was actually common. In 22% of the patients, there was regression. But we also learned the complex interaction between regression and hematological response. So you need to switch off very deeply the production of amyloid. However, that is not sufficient. In every patient, there is a natural clearance capacity, which we cannot measure baseline, but will become obvious only once we switch off completely production. So the CMR was really adding more information on top of the degree of the hematological response. And this one is an example of regression. And at the top, very typical pictures of amyloid. At the bottom is 1 year after. You see that the left guard has completely changed and the extracellular volume has gone down. And what I find interesting is that when we started to say cardiac amyloid regression can happen, people were just saying, that's impossible. We just don't say it. But the problem was that we didn't have the right imaging to actually visualize those changes at the tissue level. And what this paper really showed is that was the first one to make a connection between the changes in ECV at 6 months, so change in amyloid at 6 months, and prognosis. And this change was an independent predictor of prognosis, so it was adding a lot of important information compared to just measuring the chemotherapy response. And why was that? Because we were imaging what was happening to really the myocardial substrate. But then can regression happen in ATTR amyloidosis as well? We did a very simple, small study, just 16 patients treated with gene and 16 controlled, so very limited analysis, extremely a lot of limitations. However, what we found is that once on echo there was no change, there was evidence of patisiran being typically associated with a fall in NT-proBNP and improvement in 6-minute walking test, and also a decline in ECV. And so even if the study was extremely small, for us was important because it was the first proof of concept that amyloid regression can happen also in patients with ATTR amyloidosis if you switch off the production of amyloid enough. What about bone scintigraphy? Bone scintigraphy is again very accurate. Can we use that to track changes over time? Whilst we see a lot of changes in the cardiac uptake, what we learned is that it's not just the cardiac uptake changes, but also the bone uptake and the soft tissue uptake. And when we think about the percentage of tracer that goes to the heart is only 2 to 3%. So when there are huge changes in the bone and soft tissue uptake, that will affect the cardiac uptake as well. And so we need to be extremely cautious in thinking that actually changes in the cardiac uptake in bone scintigraphy can be ascribed to amyloid deposits. And now actually within the kind of academic community, there is full acknowledgement that that is not the case. So a change in imaging doesn't mean that you're tracking a meaningful signal. You really need to associate that with clinically meaningful changes. And so imaging, and specifically CMR, completely transformed the way we think about amyloid. Initially, we thought if you get cardiac amyloid, you're going to die with it. And now we know it's a very dynamic process where amyloid starts to build if formation exceeds clearance, and you will see regression if clearance exceeds formation. So in conclusion, what is wrong with what we have? So we lack accuracy and precision, because we really need to image by biology and specific pathways, and the link to therapy is really what we want. In terms of imaging in amyloid, the current evidence is that echo is extremely key to raise the suspicion, but it's really CMR with leg-guard and then bone scintigraphy, which helps in the cardiac phenotyping. And then mapping is useful to actually measure and quantify specific pathway, and the link to treatment is really the greatest promise. Thank you very much for the attention.
Yeah, thank you, Marianna, for an exceptional, really exceptional presentation. I'm a humble EP cardiologist, so I have an attention span in milliseconds. So normally I fall asleep during imaging talks, but you kept me focused the whole way through. So we have time for a couple of questions. And Marianna, are you able to stay for the panel discussion later?
Yes.
Oh, super. So we have time for a couple of questions just now, or folks can save them to the panel discussion after.
Hi, Marianna. That was a fabulous talk. Very, very interesting. Do you have any idea? So this idea that amyloidosis is dynamic is a game changer, because clinically people often view it as a fatal disease. In your experience, do you have any idea? And I don't know if you're a radiologist or a cardiologist. Do you have any ideas of the factors that are ameliorating amyloid formation versus clearance? Like, do you have any idea about that?
So first, my disclosure is that I'm a cardiologist. So yes, I see these patients clinically. And I was lucky enough 1.5 years ago to completely stumble across, whilst I was reporting CMR scans, to 3 cases of cardiac TTR amyloidosis who completely regressed, like where there was full-blown cardiomyopathy, and after a certain period of time, they went back to normal. I mean, David, like your EP, even the ECG voltage went up, in the sense we saw that the ECG voltage went back to normal, the echo went back to normal, CMR back to normal, peak VO2 on CPET went back to normal. It took us 1.5 years to figure out what was happening there, and finally was published in the New England Journal of Medicine in the end. We learned, going back to the mouse model, because this one is a very translational department where I work, and very lucky, so we were able to go back to the mouse model, transgenic for human TTR, and we were able to prove that these patients very uniquely, and I mean, it was just an unbelievable thing, that they were able to develop autoantibodies against the amyloid. And so the antibody, we had a cardiac biopsy in one of these patients and was full of CD68 positive cells, so macrophages infiltrating the extracellular space and just eating up the amyloid. And for us, that, I guess the reasons why then it got published in the New England was that it was the first proof of concept that ATTR amyloidosis is an entirely reversible condition. If you've got the right compounds that can go there and remove the amyloid, it just can go back to completely normal. So, yeah, so that was, I mean, that was something that made us completely change the way we look at the disease. We always think about amyloid as a disease of misfolding, and now we believe that it's a disease of misfolding, but also absent clearance. So if you develop amyloid, it's because you misfold, but also you cannot clear the amyloid itself. Maybe clearing the amyloid is an entirely normal phenomenon, which happens in most. So
yeah, that's fascinating. That's fascinating.
The clearance aspect is going to really be the hot topic for the next 5 years.
There's time for one more question, and there's a question in the chat for you, Professor, and that is from Chun Koo. Thank you for the great talk. Nowadays, we receive a lot of CMR reports with ECV is elevated, and this is suggestive of administrative diseases like amyloid. Should we be working up all of these patients for cardiac amyloid? Do you know how sensitive specific is elevated ECV?
Yeah, absolutely not. In the sense that that's like what happens when we introduce new technique. We get all excited and then we get lots of false positives. So extracellular volume per se is not a specific marker, because extracellular volume goes up because of fibrosis, because of edema. Anything that occupies extracellular space will increase the extracellular volume. However, it becomes specific is the degree of increase, because if you find diffuse Legad and an ECV of 45, 50, or 60, basically it can be anything else apart from amyloid. So the most important thing is to relate the ECV with the Legad pattern. Because if you have a patient with severe AS and you see some patchy Legad and the ECV is 33, 34, you shouldn't really do anything. It's about the pattern of Legad and the degree of elevation in ECV. Anything above 40, I definitely would go for further testing.
Okay, that's very helpful. Okay, well, we'll swing back to you at the panel discussion, and I'll move on to introduce the next two speakers. So another way to keep me awake during conferences is to have debates. So we have a debate, which is fantastic, and the debaters are Gavin, Oudit, oh gosh, I'm sure I mangled that, professor, staff cardiologist, clinician scientist at the Mesana, Alberta Heart Institute. His clinical interests are heart failure and cardiomyopathies. He holds a Canadian research chair in heart failure, director of the Heart Function Clinic, and a fellow of the Canadian Academy of Health Scientists. And he is going to be debating Julie Richer. She's a medical geneticist at CHIO, which is the Children's Hospital here in Ottawa, an associate professor at the University of Ottawa. Clinical practice primarily consists of the care of patients with underlying connective tissue disorders. Our academic interests include genes responsible for familial aneurysms and vascular dissections, etc. So the debate title is Genetic Testing Should Be Routinely Incorporated in the Investigation of Patients with Hypertrophic Cardiomyopathy. And on the pro side is Gavin, and on the con side is Julie. So I think Gavin is going first.
Yeah, great. Thank you, David. Thank you for that wonderful introduction, and great to be doing this with Julie. And I would like to thank Ian once again for inviting me to speak this year. So yeah, sure, it's a debate, but hopefully at the end of this, we'll all come to an agreement. So I'll I guess I have to share my screen, right?
Yeah, please.
Okay. Let me see how I can do this.
You should at the very bottom if you click up from the bottom. Yep.
Yeah. Okay. Does that work?
Yes, it's working very nicely. Thank you.
Okay. Is that in presentation mode now?
It's not. It's still in slide mode.
Why is that not working?
Are you working with two screens, Gavin?
No, just one screen off my laptop.
And it's in presenter mode on your laptop?
Yeah, there is. Okay, is that better?
Yeah, it's perfect.
Okay, great. So thanks again. So I'm here to advocate for genetic testing, and really to advocate for patients. My title is slightly different, non-ischemic cardiomyopathy. I think the concept is all the same. It's really to advocate for greater understanding of genetics, its role in cardiomyopathy, and the use of genetic testing in our patients. So these are my disclosures. So we're all well aware of the genomic revolution in medicine. It was driven by next generation sequencing, and so we can now look at panel-based testing in our patients, and then proceed to whole exome sequencing, whole genome sequencing. As you can see, the cost of this now is dramatically reduced, now to almost a few $100s per test. So this is quite amazing. truly a revolution in medicine, not only in cardiology, but all of medicine. And so we really should be thinking of ourselves as a molecular cardiologist. For those of us who do this type of work, cardiomyopathies, arrhythmias, and congenital heart disease. Now, of course, vascular disease, as Julie will highlight shortly. So I think the era of molecular cardiology is here. We need to embrace it, and we need to use it appropriately. Like anything that's good, if it's misused or misappropriated, it can be damaging. So that's something to keep in mind. So types of cardiomyopathies, this is from our CJC review, mainly driven by hypertrophic and dilated cardiomyopathies, almost with equal prevalence within new data, and dilated cardiomyopathy showing this is a lot more common than we previously recognized. They are the rare versions of cardiomyopathy, arrhythmogenic cardiomyopathy, restrictive cardiomyopathy that are much more higher mortality associated with them, and this concept of LV non-compaction, which is really a variant, not a well-defined cardiomyopathy. So fairly prevalent conditions, not only in young folks, but also in our older patient population. So this is a very nice, insightful review taken from the American Heart Association, published now almost a decade ago. And so when I was an undergrad student, that right-hand column there was close to 0, right? So the first genetic cause for cardiomyopathy was, of course, discovered by the Seidmans, actually with a cohort from Quebec of hypertrophic cardiomyopathy. And now we're looking at detection rates of up to, in the real world, probably up to 30%. And if you look at truly familial cardiomyopathies, it can be maybe up to 50%. But it also extends, of course, to inherited arrhythmias, vascular disease, and so on. So it's expanded into many other things. Familial hypercholesterolemia, as you all know, work from Quebec showing the impact of genetics there. So quite transformative in terms of the impact and these conditions, which are fairly common, and I think we all see them in our regular practice. So it's taken from that statement. It's a very nice statement. It's an older statement, but it really reflects how we should be thinking about genetics and how we should be incorporating this. So we're looking at, of course, diagnosis, prognosis, and therapy. So the 3 hallmarks of what we do as clinicians. And so, of course, they're important for diagnosis. They're important for prognosis. Probably the most striking example would be someone with a lamin mutation, a very deadly dilated cardiomyopathy, where you jump the queue and get your ICD put in as soon as you have that diagnosis made. So that's a striking example of how you can change the outcome of patients. Of course, directed therapy for infiltrative cardiomyopathy, and I'll show you some example of that. And then this is, again, part of a whole process that involves a multidisciplinary team, family, and their patients and their families. So you need to think beyond your proband, your patient, and think more about the family. And that's also a very exciting opportunity to be able to deal with the entire family and have an impact on the entire family. So cascade screening and the impact of multi-generational families. When we think of genetics and cardiomyopathy, I mean, these are the 5 classic divisions of the genetic results. So we want to be aware of class 1 and 2, the likely variant driving the phenotype. In class 4 and 5, likely, unlikely. So class 3 has become a real challenge for us. And I think Julie will touch on this. GVAS, variants of unknown significance. It's there. It's probably part of a polygenic risk score. As I noted, only 1/3 of our patients have a defined genetic cause for cardiomyopathies. The others are probably polygenic, often with interaction with environmental cues, factors. So I think the class 3 has become very prominent as we expanded our genetic testing. And rather than running from it, we need to understand it like we typically do. And it's part of what has made cardiology so exciting. So we take on challenges and we address them rather running from them. So I think we will see a lot of that. And again, they're probably part of a polygenic risk driving cardiomyopathies. So just to highlight, as we deal with these patients, yes, there's a genetic basis for cardiomyopathies. Importantly, to understand the modified genes, these might be your variants of unknown significance. Huge impact of environmental, and I can say probably the two most important one we have seen is hypertension and alcohol intake. So important to talk to patients about those, and to be thinking about how to incorporate those as part of your genetic assessment and the management of patients, as we try to fine-tune the genotype-phenotype relationship in patients with inherited cardiomyopathies. So this is again taken from our review. So on the left, you're dealing with the typical monogenetic causes of cardiomyopathies, and the right, probably the more polygenetic, where there's a big impact of the environmental and polygenic risk score, which is now becoming almost clinically indicated in the US. There's a big push to incorporate polygenic risk score now as one of the additional risk factor, risk stratification in patients with actually fairly common diseases. So you can go from a well-defined monogenetic disorder to now a polygenic risk score. So I think we need to understand the changing spectrum of genetics and how to apply it. This is the text here may be difficult to read. This just came out 6 months ago, ESC guidelines and cardiomyopathy, class 1 indication for genetic counseling in patients with cardiomyopathy. But importantly, they also recommend this for patients who have died, unfortunately, from their cardiomyopathy. So this is kind of like the molecular pathology. And so I think that's important. And we have a program now in Alberta looking at this. So not only in our living patients, but patients who unfortunately have died, it's a class 1 indication to look at genetic counseling and to study those patients and, of course, their family members. And quite often the families are very motivated to understand what has happened to their deceased family members. So that's an important addition that genetic testing has brought to our clinical tools, molecular autopsy. And on the right, you can see again also a class 1 indication for family members, cascade screening. Okay, so class 1 indication all the way through. Genetic testing and counseling must be a multidisciplinary approach. You're looking at multiple generations. You're looking at working with your genetic counselors. You're looking at interpreting the results of those genetic testing and going back and understanding, incorporating all of your ECG, other clinical data, imaging data, so critical, and then putting it all together. And often meeting regularly with patients, but also with your colleagues in genetics to be able to better understand what's happening with your patients. The second half, I just want to highlight the impact of this we have had here in Edmonton. We have actually taken this to heart, and we have actually started a cardiomyopathy clinic. And I just want to highlight here some of the data we have generated from this clinic. So on the left there, you can see referral from many colleagues, primary care physicians, pediatric cardiology as patients graduate into the adulthood, multidisciplinary referral to us outside of Alberta, also as a big referral center for Western Canada. And we have actually taken this on and looked at our patient cohort. So 421 patients, a huge fraction of them with dilated cardiomyopathy, but also certainly hypertrophic cardiomyopathy, infiltrative cardiomyopathy, and importantly, patients at risk for cardiomyopathy. So the stage A, stage B, heart failure classification, so before they become symptomatic. This is the results of some of that. So 421 patients. Importantly, in the top right, you can see some patients do decline genetic testing. And so that is something we continue to work on. This is the language, the new technology that we need to do better at in terms of explaining this to patients and their families. But most patients do proceed with genetic testing. And as you can see, 1 in 3 of our patients were genotype positive. And the results of the genetic testing are shown on the right. So dilated cardiomyopathy, not surprised, Titin dominates there, but a whole host of other mutations, including lamin, FNLC, these are very arrhythmogenic cardiomyopathy where you can make a really big difference. BAG3 mutations and some channelopathies, you can clearly change the outcomes of these patients. And of course, in the hypertrophic cohort 2 dominated myosin binding protein C and myosin heavy chain mutation. Importantly, we have also detected infiltrative cardiomyopathy, both Fabry's and TTR amyloidosis, and of course, a huge fraction of patients at stage A. So these are patients that have been referred to us because of family members or family history of a cardiomyopathy. So that's also a big impact. So with this clinic, we have been able to, I'm running out of time, so I'll move quickly. In this clinic, we've been able to up-titrate therapies. So you can see on the left there, the left-hand bars are pre-clinic, the solid bars are post-clinic. We have an up-titration of medical therapy, all 4 classes of quadruple therapies. We have started patients on specific therapies, ERT for Fabry's disease, tafamidis for amyloidosis. We have also engaged in cascade screening for family members. We do not refer this to family doctors to do. This is our responsibility to screen family members. If you want it done properly, you do need to take it on. And again, also increase use of defibrillators and CRT-D, especially those patients with highly arrhythmogenic phenotypes like the lamin and FNLC mutations. So with this, you can see a triple quadruple therapy. On the right, you can see a very prominent improvement in, you can see the range of the ejection fraction in these patients, and you can see a very prominent increase in ejection fraction in our clinic, especially in patients with stage C, but importantly also in stage B patients. So patients without heart failure, you get a very significant rise in ejection fraction. So associated with a reduction in LV and diastolic dimension, so reverse remodeling. So very impressive data in this fairly large cohort. So with our infiltrative cardiomyopathy, we've been able to start patients on specific therapies. And in fact, patients that had a reduction in ejection fraction, we're starting to see now a normalization of ejection fraction and a reduction in LV mass index, in particularly in the Fabry's cohort. So these are, again, very important findings in patients with infiltrative cardiomyopathies. Finally, biomarker assessment. I'll just talk about what we see on the bottom. You can see before and after, both significant reduction in BNP, NT-proBNP, and even high-sensitive troponin in the eye. So not only based on imaging results, but also on biomarkers, we're seeing this reverse remodeling. Importantly, we're actually able to normalize patients' blood pressure and reverse their some of their hypertrophy and hypertrophic cardiomyopathy. Hypertension has become a forgotten part of cardiology, and managing high blood pressure is important in patients with hypertrophic cardiomyopathy. So that's another benefit of doing genetic testing and managing the whole patient, not only the genetic testing results. Okay, and if we look at outcomes now in our cohort, very low outcomes. This is now outcome data for about 2.5 years. So very low hospitalization in our stage A, stage B patients. So pretty impressive that patients with mutations and cardiomyopathies, the mortality rate remains very, very low. And in fact, only in a stage C do we see a progression of mortality and hospitalization. So that's pretty impressive results. Now, it is only 2.5 years of a median follow-up data, but of course, we continue to follow this cohort. And then finally, we're of course looking at new therapies. So genome editing, gene therapy. So this is now on board. This is part of our international collaboration where we're defining the genetic basis of cardiomyopathies and understanding how it brings about cardiomyopathies, and then of course correcting this. So we have just published this on the dilated cardiomyopathies. We're now about to publish on the hypertrophic cardiomyopathy. And of course, many of these gene editing, gene therapy are in preclinical studies, and some of them have entered into clinical studies. So another important reason to do genetic testing, because if you don't know what you're dealing with, you can't treat it. So in conclusion, genetics in cardiology certainly revolutionized our approach to cardiomyopathies. It has to be a multidisciplinary approach. The Genetic Non-Discrimination Act, I must say, is a wonderful legislation that is now in Canada and the US that has helped to protect patients and their families. The importance of this has been highlighted in recent guidelines, as I highlighted there, the ESC guidelines. With the improvement in therapies, this is no longer an exercise in academia. We have GDMT, we have fancy device therapies, including subcutaneous ICD, which a lot of young patients with cardiomyopathies that have a high risk of ventricular arrhythmias and sudden cardiac death are electing to use, and of course are associated with reduced risk of complications. So that's an added bonus. And specific therapy, precision medicine, certainly there for infiltrative cardiomyopathy, but now coming on board for hypertrophic and dilated cardiomyopathy. Some of these are already in clinical trials, and we are part of some of those approaches. So I think you're going to see a lot more of this very specific therapies now coming on board for different types of cardiomyopathies. So overall, very excited and about genetics and cardiomyopathies. I think we should all do it. Of course, and understanding, of course, the benefits of it, but of course there are certain issues and a risk, and I'm sure Julie will be telling us more about that now. Thank you. Thank you. Finally, just a lot of great people to work with here in Edmonton, our clinics. Actually, our cardiac surgery that have explanted heart program that has really allowed us to understand more about cardiomyopathies and genetics. So great guys, great trainees that worked with us over the last decade, colleagues in medical genetics. And now we're part of national registry, so the HERO HCM with Rafiq, and the DCM registry with Julia, both from the Montreal Heart Institute. So we're glad to be part of those initiatives also. Thank you.
Thank you, Gavin. A very powerful argument there. So we'll now turn to Julie, if you're there, to give us the con side of things. The most important of the rare cardiac conditions, which is of course sarcoidosis, highly biased. One of the joys to me of getting involved in a rare cardiac disease is you get to meet all these people who are not cardiologists, and I've got very involved with WASOG, which is the World Association of Sarcoidosis, and met wonders through that. And I have to say, I find most people in the sarcoid world to be, in general, a little bit nicer than EP cardiologists. So I really enjoy working with them. So I'm going to introduce Wonder now. She's a professor of medicine at the University of Maryland School of Medicine. She's also the Senior Associate Dean of Faculty Affairs and directs the Sarcoidosis Center of Excellence. She's got a basic science lab which conducts a full spectrum of research, from basic investigation to translational research, all the way to clinical trials. And her lab was the first to describe novel mycobacterial sequences in sarcoid tissue specimens, as well as to demonstrate that mycobacterial virulence factors were targets of the adaptive immune response. She's led a robust research program, 68 trainees, and particularly vocal regarding the importance of supporting careers of diverse scientists, women and minorities. So I'll hand it over to Dr. Drake. There's somebody who's not on mute, so if you could all just check you're on mute, because I'm hearing a little bit of background noise. We'll hand it over to Dr. Drake.
Good morning. It's truly my pleasure to share in this conference. I'm learning so much. Let's see. So can you see my full screen? Is it showing full screen or presenter mode?
It's showing presenter mode right now.
Okay. I tried to fix this. Okay. Let's try it one more time. I apologize. Gavin, I guess I want to be you when I grow up. Haley, I'm going to try this one time, and if it doesn't work, then we'll just let you pull it up since you have my slides. Is that okay?
No problem.
Yeah, why don't you go ahead and bring it up because it's still doing presenter mode for me. In America, we have this show called Wheel of Fortune, where you go next slide. So that's what we'll do. I actually studied pulmonary sarcoidosis, and I did explain this to David, but I will at the end tie in what we found in lung disease, because I do think there's a lot of corollaries to heart disease. So unlike Gavin and Julie, which showed some really fascinating data regarding genetics, I'm really interested in the environment and the impact that the environment, particularly the gut microbiome, has on organ function. And so I'm going to discuss the importance of the gut microbiome in rare cardiac diseases. So next slide, please. And I don't have any financial disclosures. Next slide. So I'll begin by introducing this concept of the gut-lung axis and discuss what has been published, its impact on chronic lung disease. And then I'll provide in vivo confirmation using marine models of this negative relationship we see with gut microbial diversity and lung fibrosis severity, meaning that the lower the diversity is, the more severe your lung disease is. And then I'll present, because I'm also an immunologist, we'll present concomitant immunologic profiles and marine models with high and low gut microbial diversity, and then discuss the mechanisms that have been hypothesized to date and how gut microbiota impact cardiovascular disease. Next slide, please. So the gut-lung axis, is it our friend or is it our foe? And the answer is both. It actually depends upon where the type of microbiota you have in your gut. So we know that in terms of health, we've got bacterial ligands such as LPS, short-chain fatty acids, and migrating immune cells that actually will modulate the immune system. And they can do so in a positive way, which leads to a healthy lung environment and effective clearance of infection, but also in terms of gut dysbiosis. And we define that as an imbalance in the microbial community in a form that favors the increased presence of pro-inflammatory bacteria. So all patients, those doing well and those doing poorly, have the same types of bacteria in their gut, but the percentages vary significantly. And it's when these percentages are tilted in the favor of pro-inflammatory bacteria do we have what's called gut dysbiosis. And there are a lot of things that impact gut dysbiosis, whether it's infection or antibiotics or cigarette smoke. This leads to poor lung disease, which can affect your immune system and then affect lung function. Next slide, please. So we use the intranasal bleomycin model, which is an accepted model, the primary model for assessing chronic lung disease, particularly lung fibrosis. The mice we use are wild-type C57 black 6 mice who undergo an intranasal challenge of bleomycin. We leave them in their cages, and then 14 days later, we harvest organs. And for this particular study, we harvest their lungs and their gut, the stool within their gut. With the lungs, we quantify the degree of fibrosis in their lungs. We create single-cell suspensions so that we can define the immunologic milieu. And then we do either immunoblot analysis or real-time PCR, looking for molecular mediators of our observations. Next slide, please. So I've only been at University of Maryland for a year. Prior to that, I was at Vanderbilt. And in the South, they're real nice. I got this email saying, Dr. Drake, going forward, we're going to move your mice from the ABSL2 facility to the ABSL1 facility. Have a nice day. And no question at all what impact it has on me or anything. Just have a nice day. Next slide, please. So the reason it matters is in the ABSL1 facility, there are no infectious inoculations whatsoever. There are marine experiments happening, but none that involve infectious antigens. This is in comparison to the ABSL2 facility, where there are infectious inoculations happening around the mice. And I had on my animal protocol permission to do infectious inoculations, but I hadn't done any in like 3 years. It was totally based on, but because I wanted permission to do it, I was in the ABSL2 facility. I didn't think it mattered that they were moving me to the ABSL1 facility, but it turned out it did. When they moved us to the ABSL1 facility, our mice stopped getting sick. They stopped developing fibrosis. And it was the same time where I had brought in a new technician. So it took us a while to figure out that it wasn't the new technician, but there was actually something else going on. Next slide, please. So one of the markers that we use with mice is we assess their survival over the 14-day period. And typically when you give bleomycin, you see a difference by sex, in that about a third of the male mice will die, but they never make it to day 14. They die of pulmonary insufficiency if you give them bleomycin. However, if you give them normal saline, they do just fine. This is a survival curve of a mice that we gave normal saline, and as you can see, they have 100% survival, and then there's no change in their collagen content. So we had 3 housing conditions: germ-free, ABSL1, where there's no infectious inoculations, and ABSL2, where there are other investigators doing infectious inoculations. We weren't, but our mice were housed in those conditions. Next slide, please. In stark contrast, when we gave the mice bleomycin, we saw very little fibrosis in the mice that were housed, who received intranasal bleomycin, but were housed in the germ-free condition. There was an intermediate median in the mice that were housed in the ABSL1, and the highest overall was in the mice that were housed in the ABSL2. And this was histologic. When we quantified collagen content, again, we saw a very little difference in the ABSL, in the mice that received normal saline, irrespective of their housing condition, whether it was germ-free, ABSL1, or ABSL2. However, when we gave bleomycin, we saw a low-level collagen content with bleomycin in the mice housed in germ-free conditions. However, if we gave the mice that lived in the ABSL1 facility where there were no infectious inoculations, they had an intermediate, and then the highest was in the mice that received intranasal bleomycin that were also housed in the ABSL2 facility. Next slide, please. What we noted was that mice that received intranasal bleomycin had the same degree of fibrosis as the mice that received normal saline, basically our controls, suggesting that there was something other than intranasal bleomycin that was driving fibrosis. Next slide, please. And we also noted, as I pointed out, that there was a step, as you exposed mice to microbial agents, we saw worsening of their fibrosis, and the all-time worst was in the mice that received bleomycin, but also the mice that received bleomycin also housed in the ABSL2 facility. Next slide, please. So then we started figuring out maybe it was the microbiome. And as I told you, I spent a few months thinking it was the technician and trying to change experiments. It wasn't until the experienced technician did it and got the exact same results that I thought, oh, wow, it's something else. And I can remember just sitting in my office one day and I thought, oh, golly, it's the microbiome. I said, it's truly the microbiome. So we looked at the lung microbiome first because there was a really nice Blue Journal paper that showed, which is the top pulmonary journal in the United States. There was a Blue Journal paper showing that in patients with idiopathic pulmonary fibrosis, their lung microbiome and a reduction in the diversity of the lung microbiome was associated with reduced survival. And so we looked at the lungs of the mice, and to our surprise, there was no difference in their diversity of the mice by housing condition. The germ-free mice were truly germ-free. The only DNA we detected was that associated with the reagents we were using to process the experiment. But as you can see in ABSL1 and ABSL2 in the lung, there was no difference. And this also panned out according to treatment. Like we honestly didn't see a difference whether in ABSL1 or ABSL2. This data shows the second panel that the treatment did not seem to be the driver for the differences that we were seeing in the lung. Next slide, please. But then we looked at the gut microbiome. And that's where we saw a significant difference. So the red dots on the left, so the Shannon diversity is basically a quantification of the degree of diversity you see in by labs. And we saw the highest diversity in the ABSL1 compared to the ABSL2. And when we did further investigation, we saw that in the ABSL1, there was higher quantitative and qualitative diversity compared to ABSL2. And again, treatment did not seem to be a factor in this at all. And when we looked at the bacteria that were present in the ABSL, so the red bars are ABSL1, and we saw what others have reported in the literature for a good prognosis with lung disease. We saw Bifidobacterium, Dubacillia, Proteobacteria, Lactobacillus. And then in the ABSL2, we saw, again, what's been reported in the literature among people with good lung function, poor lung function, Bacteroides, Lachnospiraceae, Firmicutes. Next slide, please. And so this presence of Bacteroides and Firmicutes in a much higher quantity, like we definitely detected these quote unquote bad bacteria in the ABSL1, they were just significantly less. And then we can also detect Lactobacillus, Bifidobacterium in ABSL2 is just significantly less. So it seemed that ABSL2 mice actually had gut dysbiosis. Next slide, please. And this is just confirming what I'd shown before. Next slide. And this is just looking at different aspects of diversity, microbial diversity. So either Shannon diversities, pillows, evenness, or species richness. And this was the one-liner for this is to show whether we gave the mice saline or bleomycin, there wasn't a significant difference in diversity. Now, when we looked at the ABSL1, ABSL2 facility by species richness, there was a hint of possible significance, but it wasn't less than 0.015. It was almost equal. Next slide, please. So what we've learned so far is that mice that are housed in germ-free conditions or in housing conditions that promote gut microbial diversity experience less lung fibrosis following acute lung injury. And that mice that are housed in conditions that favor a lower gut microbial diversity experience more severe lung fibrosis, which impacts their morbidity and their mortality. And then microbial diversity in the gut promotes less severe lung disease in marine models for sure. Next slide, please. What we found, so we were interested next in how the gut microbes might be doing this. And there is some literature suggesting that bacteria that are associated with gut dysbiosis, such as Bacteroides, can be an inducer of natural killer T cell activation. There was a Nature paper. We saw that segmented filamentous bacteria can induce the production of what we would call Th17 cells. And it's also been shown that Faecobacterium rosaburia and Lactobacillus can actually produce short-chain fatty acids, and these actually can reduce inflammatory T cells, such as Th17 cells. Next slide, please. So there's a growing appreciation that the bacteria in our gut do more than just comprise our stool, that they're actually modulators of the immune system. So, for example, we're all familiar with H. pylori and its ability to induce ulcers, but H. pylori also through its VAC-A, which is important, impacts dendritic cells, which can go on to reprogram immunosuppressant cells such as Tregs. Bifidobacterium and Lactobacillus can produce short-chain fatty acids, which can also impact immune cells. Bacillus fragilis, through its PSA, could actually increase IL-10 production, and then structural components of bacteria, whether it's LPS, flagella, or flagella, etc., can impact not only T cell, dendritic cells, but also neutrophils, T cells, and B cells. And this can lead to increased inflammation as a consequence and increased antibody production. Next slide, please. So one of the things we know is that in order for lung fibrosis to occur, you need Th17 cells. And Th17 cells, so dendritic cells can produce IL-1 or IL-6. And then a CD4 T cell can, through transcription of STAT3 and VOR-T, actually become a Th17 cell. And so it's sort of like, for those who aren't immunologists, for example, I'm Wonder Drake, there's John Drake, and then our twins, Cameron and Miles Drake. So we're all Drakes, but we're different types of Drakes. There's the mom Drake, the dad Drake, the twin Drakes. Immune cells are the same way. They're all CD4 positive T cells, but there's different types. And this Th17 cell is particularly important because it can produce a cytokine, IL-17A, which once it's that cytokine is in contact with epithelial cells, has downstream effects that can promote inflammation. Next slide, please. So one of the things we did was assess when we looked at the lungs of the mice that were harvested at day 14. We looked at those that were housed in germ-free, those that were housed in ABSL1, those that were housed in ABSL2. And we actually we looked at their immune profile to see, did it support that they were going down a Th17 pathway? And we noted that they did. So we saw very little IL-6, its receptor GP130, or IL-17A in the mice that received normal saline, or even the mouse that received bleomycin but was housed in a germ-free condition. However, if we looked at the same cytokine expression in ABSL1, there was low IL-6, as well as its receptor GP30, and an intermediate IL-17A. However, if we looked at the mice that were housed in ABSL2 conditions and received bleomycin, there was significantly higher IL-6, GP130, which is its co-receptor, and IL-17A. So this suggests, and this phospho-STAT3 parallel this same phenomena. So the one-liner is that the gut microbiota, when you have low gut microbial diversity, it's associated with increased expression of these pro-inflammatory T cells, specifically Th17 cells. Next slide, please. So to more conclusively show, because it's an association up to this point, we took our germ-free mice and we actually gavaged them. So we took stool from ABSL1 mice and stool from ABSL2 mice. We created a stool slurry, and then we placed that slurry into the stomach of a germ-free mouse. So there was a germ-free mouse that remained germ-free, a germ-free mouse that received stool from an ABSL1 mouse, so it's no longer germ-free, and a germ-free mice that's received stool from an ABSL2 mouse. We did that gavage for about a week, every other day for a week, and then we gave them intranasal bleomycin. Let them go 14 days and assess for the degree of lung fibrosis. And so what you can see is, so weight loss is a predictor that the mice are developing lung fibrosis, and we saw the lung fibrosis in the germ-free mice that received ABSL2 stool. When we looked at collagen content, there was no difference in the quantification of collagen between a germ-free mouse and a germ-free mouse that received ABSL1 stool. However, there was more than double average of a germ-free mouse that received ABSL2 stool compared to its one that received ABSL1 stool or one that remained germ-free. And then these mice have normal immunity. They've just never seen antigen. And so at day 14, we didn't have a ton of mature cells, but we did have significantly higher CD4 positive T cells. And when we looked at STAT3 expression, the transcription factor for making Th17 cells, that was also high. And then you can just see when we quantified fibrosis, the blue indicates the so we did regular H&E stain or trichrome, and you can see there's some inflammatory cells present in germ-free, but very little blue. And there was also very little blue in the germ-free mice that received ABSL1 stool, and significantly higher blue in the germ-free mice that received ABSL2 stool. Next slide, please. Another group, so just a synopsis that this suggests that the bacteria in our gut are actually able to ameliorate our immune system and worsen lung disease, the severity of our lung disease. Another group at an independent institution, they were actually at University of Chicago when they did this study, found similar findings. They did not use germ-free mouse. They used specific pathogen-free mice, and showed that if you add the feces of mice from an ABSL2 condition to their bedding, that they also had worse survival and increased weight loss. They did not actually measure fibrosis in this study, but it does suggest in an independent lab that they also found that if you gave induced gut dysbiosis, you get worse lung disease. Next slide, please. So I know you're all cardiologists, and what does this mean in the world of cardiology? And, you know, surprisingly, there's no information regarding gut dysbiosis in like cardiac sarcoid, for example. I think it would be a very fascinating study to do because I'm amazed at the number of cardiac sarcoid patients that have a really high weight BMI. So, but they have done gut dysbiosis in more common diseases such as atherosclerosis, and it suggests that it is important. So in this particular slide, there's reports where they show that patients that receive a high-fat diet, if you look at the microbes, these microbes can induce trimethylamine, which then undergoes oxidation by the liver to produce trimethylamine N oxide. That particular chemical, TMAO, can induce platelet activation and thrombosis. These microbes also, through their LPS, peptidoglycan LPA, can induce metabolic intoxemia and actually induce atherosclerosis. And then if you have a fiber-rich diet, you can have short-chain fatty acids, and it depends on which fatty acids that are produced, because generally this is a positive to have short-chain fatty acids, but they do show some evidence of blood pressure regulation. So they're tying these high-fat diets, the consequent gut dysbiosis, with different mechanisms that result in atherosclerotic cardiovascular disease. Next slide, please. And so the synopsis that they're proposing is that whether it's TMAO and its impact on platelet activation and atherosclerosis, short-chain fatty acids, secondary bile acids, or uremic toxins, they can all induce inflammation and cardiovascular disease. Next slide, please. There is some work suggested in pulmonary hypertension, and I think it's just because the heart is so difficult to biopsy and it's a little bit more difficult to prove, and we don't have as great a models as we would like for cardiac sarcoidosis. But there is a report showing that gut dysbiosis increases pulmonary hypertension, and through the same mechanisms that I'm proposing, an increase in TMAO, a reduction in their short-chain fatty acids, and then an increase in serotonin also, which is gut microbiota have been shown to produce. This leads to inflammation, particularly IL-6, akin to what I showed you in our mouse model, and IL-17A. That increase leads to vascular remodeling, specifically fibrosis, which leads to increased blood pressure. You get an increase in your PVR as well as your RV afterload, leading to RV dysfunction, which leads to venous congestion and lower cardiac output. Next slide, please. And then they've even looked at the bacteria associated with it, and specifically the mechanisms associated with an increase in pulmonary artery hypertension, whether it's an increase in intestinal permeability, an increase in hypertension. They've also looked at microorganisms associated with tryptophan synthesis, which is important in T17 generation also. Tryptophan metabolism, I'm sorry. Next slide, please. So in conclusions, in humans with lung fibrosis and in marine models with lung fibrosis, low microbial diversity, whether it's in the lung, which has been reported with humans, or in the gut, which I demonstrated in my marine models, is associated with inflammation. Intranasal bleomycin in ABSL2 mice, which have low gut microbial diversity, leads to increased IL-6 and IL-17A, predominantly from Th17 cells. And that if you gavage a germ-free mouse with low diversity stool, they actually get more severe lung fibrosis compared to a germ-free mouse. And then also want to show that gut microbiota impact a more prevalent cardiovascular diseases such as atherosclerotic cardiovascular disease and pulmonary hypertension. But when you consider what I've found in the lung and what's been reported in more common cardiovascular diseases, it's very reasonable to look at this as a factor to investigate this possibility in cardiac sarcoidosis. Thank you. Oh, and this is an amazing team that did the work that I showed you. Thank you.
Yeah, thank you, Professor Drake, for an outstanding presentation. You know, classic scientific serendipity. It's just incredible.
Yeah, I was like, what? You're kicking me out?
Yeah, oh, just an amazing story, and you know, and very fascinating because you know we've actually just developed a cardiac sarcoidosis animal model in our institution, and I'd love to talk to you offline because you know we also recently showed you know there's always been this negative association between smoking and development of sarcoidosis in pulmonary sarcoidosis, and we've just shown the same thing in cardiac sarcoidosis, and it's utterly profound in cardiac sarcoidosis and completely independent of social class and all the other you know demographics. So we've been really puzzled why it's so profound, and you know maybe it's all the gut microbiome.
Yeah, it'd be interesting for you to look in your model.
Yeah, no, very fascinating. So we're ready for panel time. Unfortunately, our friend from London had to go back to work. So we've got one question in the chat, but I'd welcome more questions in the chat. And here's one from one of my cardiac sarcoidosis friends in Canada, Elizabeth Swigum. Of course, $1 million question: can we prescribe a low inflammatory diet and gut biome enriched diet for benefit?
Yeah, so I think I definitely published a case report where we saw a patient had a high BMI with pulmonary sarcoidosis, fairly severe disease, got a gastric bypass, and her disease completely resolved. She actually had lung fibrosis, and it completely resolved in 6 months. Her lung function test normalized, and her immune panel is akin to someone with good disease. So I think it's reasonable for us in a rigorous way to investigate this. And I think we have to understand too, human beings are not good at controlling food intake. So we will have to, it's a really difficult study to do, other than checking their microbiome and saying it's not consistent that you stopped eating hamburgers. You know what I mean? You know, I think it's very reasonable if someone has a gastric bypass or some other reason to assess does their cardiac disease get better. Because I was really fascinated by Dr. Fontana telling us that amyloid is reversible. And could we look and see did the gut microbiome change there?
Yeah.
So I think the mouse studies are the easiest, though.
It's fascinating, and you know, my cardiac sarcoidosis patients always say to me, you know, is there anything I can change in my diet that might make a difference? I always say, no, there's nothing you can change.
I have seen patients where we surprisingly, in lung disease, just having them poop improves their lung function. In 6 hours, they're breathing better. So that is amazing to me. We're actually doing a study now to see. And then I think long-term, I think that gastric bypass prevented her from eating all the normal foods we eat. And I didn't know about the gut microbiome at the time, but I'm hypothesizing that's why her lung disease got better.
Yeah, just fascinating stuff. So,
I have a question, David, as well, for maybe for Gavin, and I saw, Marianna had to leave. I see you have a question too, Gavin, but Gavin, what do you recommend for clinical surveillance in patients who are genotype positive but phenotype negative for cardiomyopathy? So patients who have the gene, no evidence of the phenotype, what recommend, because this is not uncommon. Clinical scenario. So what should we be doing for these patients?
Yeah, the stage A folks, right? So you're at risk, but do not have any sort of heart disease. So if you know what the genotype is, so that would modify what you do. So clearly, I think you need to understand a bit of the genetics. Obviously, if it's a higher risk mutation, whether it's hypertrophic or dilated or arrhythmogenic cardiomyopathy, you would need more frequent follow-ups. We're probably you're looking at 1 to 2 years for the higher risk folks. For the lower risk folks, you probably can drop that down to 3 to 4 years. There isn't great prospective data justifying this, but I think patients with higher risk mutations just needs to be followed closely, and with imaging, but also with, of course, things like exercise, ECG, and Holter monitors. So I think, and this is where, the cardiologist can't do this in isolation. I think you want to get EP also on board. Not to pat David on the back there, but you need EP colleagues to be part of that. So EP is part of our group, and you want to get their input, and of course our genetics colleague to understand the damaging effect of the of this mutation. The other big factor is family history. I mean, genetics are great, so they don't always capture all of the stories. So I think family history still remains one of the most dominant modifier in how we do things, right? Because we just can't capture the whole genome, right? And all the epigenetics and so on. So I think the family history is very important. So if it's a high risk scenario, mutation and or family history, you want to be very vigilant about following very closely. If it's a lower risk mutation, then you can relax and not follow up, but don't lose your patients to follow up. So.
There are some genes where we will systematically, I don't know if Dr. Hansen is here, but there are some genes where if we find a disease-causing variant, we will systematically recommend that they go see Dr. Hansen or Dr. Green because they are high risk. Typically, they're genes associated with DCM, not HCM. The other thing is that Gavin has talked about polygenic risk scores. There's actually a good paper for HCM on polygenic risk scores, and the odds ratio of those ACMG likely path variants is about 50 compared to an odds ratio for hypertension and obesity that are usually in the 2 to 3. So if you have a likely path, you're high risk, and the penetrance of all of those is known to be age-related, i.e. the older you get, the more likely you are to get it. And there's also a sex difference. So Dr. Drake said that her male mice die more. That's true in a number of genetic cardiovascular disease. They die younger. So you expect your females to, as a group, not as an individual, present later. So you can't reassure yourself as fast.
There's another. Oh, sorry. Go ahead, Gavin.
Yeah, bottom line is you need a systematic program, right? You need programs that can capture these patients together as a group and follow them, right? So, and have everyone's input. So I think it's not a one-person show anymore, right? So.
Yeah, maybe I'll follow that up with a question to you, Gavin. Then is, do you think therefore it follows that every patient in Canada with hypertrophic cardiomyopathy should be followed in a hypertrophic cardiomyopathy clinic?
No, that's a no-brainer for me. I'm biased. Absolutely. And so part of this business is learning from our patients, right? We don't do enough of this, right? So I think I've learned a lot from my patients, and I continue to learn from my patients. And so following them, having them part of the registry, so the HERO HCM that Rafik Tadras has led, and his work has been seminal. It's also shown the impact of hypertension, the synergistic impact of hypertension hypertrophy, not just additive, right? So that's also important as our patients age. So we just have to be careful with managing, be very vigilant with managing hypertension. So no, absolutely, they should be part of our clinic. They should be part of our registry, so we can understand more of this moving ahead. So absolutely, and of course, for dilated cardiomyopathy, arrhythmogenic cardiomyopathy, and restrictive cardiomyopathies, they all should be followed in a cardiomyopathy clinic.
See, Dr. Drake, with your hand up.
Yes, thank you. I guess I'm wondering, has anyone looked at them with these familial diseases? We have to realize that their environment and their nutritional environment, because families eat the same, would likely be the same. And then Dr. Paterson brought up the idea about people have the gene but not the disease. Has anyone ever looked at the gut microbiome of people with the disease, so that all of them have the same gene, but they have you looked at the microbiome of those who do and don't have the disease to see if it's different? And then could it be that familial diseases because you have the gene that puts you at risk, but you're also, because of your environment, particularly your nutritional environment, predisposing yourself to disease. Like, could you amend their gut microbiome and change disease? We've seen that in the South a lot, like people, not cardiomyopathies, but we've definitely seen people with atherosclerotic disease, that when we teach them how to eat in a way that brings in gut microbial diversity, their blood pressure normalizes, you know, they no longer have chest pain when they walk. I mean, all these things. I want you to change their microbiome.
Yeah, it's a great question. So we have done a lot of work with Maria Grant. Wonder, I don't know if you know Maria Grant. I'm sure University of Alabama.
don't.
Yeah, so diabetes and gut microbiota. So big
Mhm.
player, and of course COVID now and gut microbiota.
Yes,
Big
yes.
ACE2 in the gut. So big
Yeah.
player there. So that's been our active involvement with gut microbiota is COVID. But you know, great idea to do this in cardiomyopathies and to see how it changes their prognosis and modify the disease. So
there's another question in the chat from Elizabeth Swigum. I think it's mostly to you, Gavin, maybe a little bit to Ian as well, and also to maybe Julie. Interested in system-based challenges for follow-up and loss of follow-up. Are there patient tools to help self-advocate for time-specific follow-up?
yeah, maybe Julie.
So there are groups that are working on platforms for variant reinterpretations that would tip, and there are different types of platforms, some where patients have to check whether there's a reinterpretation available. Pushing results to patients has been difficult. The one thing that we do say, though, is that if a variant is reinterpreted and that we are informed of it, so for example, we just got a number of reinterpretations because another family was identified with the same variant, and then they went back to family A and reissued the amended reports. For patients, what's really, really important is to make sure that they keep their contact information current with where they were tested, because if we cannot find you, we will not be able to get the information to you. So I think that's probably the most important thing in the current context. I don't know if that addresses the question. I see Gavin nodding, and in terms of
No, absolutely. I think that's critical. And again, part of building registries and everyone being part of research and all of that is part of being able to contact patients. So we have also had some reinterpretation. We've actually upgraded some GVAS to pathogenic variants. So it's gone the other way. Some have been downgraded, but some have also been upgraded. So the implications there for family and family members are critical. Another piece to that is we study explanted heart in patients that goes to transplant, and we find all sorts of genetic variants. Actually, 50% of those hearts have a pathogenic variant. Those are much more damaging, right? Patients that go for transplant. So 50%. And so huge impact on families. Some of these families are actually from Saskatchewan and Manitoba, huge family members. We're looking at 20, 30 family members with cardiomyopathy. So we're now in the process of transferring those research findings back to patients and the primary care doc with approval from the ethics board. So this is where research now influencing patient care comes right full circle. So an absolutely.
Those variants that you found on the heart, you also confirmed them in the blood, right? They're germline.
Right, they're likely germline. We do not have blood samples, but they're almost certainly germline. Yeah, but there's a possibility of somatic mutations. Yeah,
So
50%, pretty high. So
you can tell Dr. Swigum's asking the important questions because they segue nicely to our next set of talks, actually, about advocacy and registry. So I think we're out of time, unfortunately, but that was a great session to kick off our conference. We're meant to meet again in 4 minutes. So why don't we say we'll reconvene in 9 minutes from now. So we'll start the next session 9 minutes. Thanks again to all of our speakers.
Yeah, great. Thank you. Thank you.
Thanks, David.
Yes, thank you very much. I'll be in touch. I'd love to chat more about some science and yeah.
Yeah, please do. I would love to. All
Yeah.
right, I have some Blue Journal stuff to do. Okay, bye-bye.
Bye-bye.